Good afternoon, everyone. After a nice meal, we are back together, and we will keep it interactive so that it's better to focus. so, so our topic for this session is ABCDE of Metabolic Health, and for this, I would like to call upon my panelists, Dr. Sanjay Shah, sir, please. He's practicing in Maninagar, and he's a very senior physician, and got a lot to learn from them. My next panelist is Dr. Mehul, sir. Mehul Shilawat, sir. Sir, please. He's practicing in Sabarmati area. He's the CEO of Panchsheel Hospital. And next I would like to call Dr. Viktanti Sailor. She is physician, upcoming diabetologist in Ahmedabad, practicing in Ambawadi area. Okay, so we'll just right away start with our discussion for this. ABCDE of Metabolic Health, the Multidisciplinary Manifesto. So now we know that we don't treat just diabetes in our people with diabetes. We see them as people. We take care of all the things that is having trouble with. So what is the primary endpoint when we talk about metabolic health? It is cardiovascular disease. So that is actually a cluster of metabolic abnormalities that occurs in the same individual, and it gives a substantial additional cardiovascular risk over and above the sum of the risk associated with each abnormality. And which is the most common components? These 6 things are easily to be observed in our patients, and this is what we focus on when we talk about metabolic syndrome. So that is abdominal obesity, atherogenic dyslipidemia, raised blood pressure, insulin resistance and intolerance, glucose intolerance, pro-inflammatory state, pro-thrombotic state. So the multidisciplinary management that we would talk about is ABCDE. A being HbA1c, B being BMI, CKD, that is chronic kidney disease, dyslipidemia, and established CVD. Okay, so we will make this interactive. I have a few basic cases that we come across in our practice very frequently, and we'll see how we can go about, how to approach these kinds of patients, different patients. So the case number 1 is Mr. A, who is 52 years old, male. He's a shopkeeper by occupation, BMI of 28.4. He presents with complaints of increased fatigue on routine activity, remains drowsy, wants to sleep throughout the day, clothes have started not fitting well. And he says that he's maybe losing weight, but he's not very sure. And no others very specific complaints. This is just vague complaints that he has. On history and examination, there is no significant past history. Family history, father has diabetes, blood pressure, and dyslipidemia, currently on all the medications. On general examination, BP is slightly raised, 142/88. Everything else is okay. Random blood sugar when tested is 178, which is high. Some investigations are advised, and this is what the investigations look like. Specifically, A1C is raised, lipid profile is a little deranged with raised LDL, and create is okay, but urine ACR is slightly abnormal. LFT, TSH is all normal. So, coming to the discussion, Dr. Sanjay Shah, sir, tentatively what approach can we use in this newly diagnosed person with diabetes?
Challenge. So as per ABCDE, I will also like to go as per ABCDE approach. A means HbA1c. Here in this case, HbA1c is 8.5. So it is more than 8. So apart from metformin, DPP-4 inhibitor, SGLT2 inhibitor, And we need sulfonylurea also to control that HbA1c 8.5 to our target should be around 6.5 to 7. So regarding HbA1c control, different sulfonylurea, metformin, and DPP4 and SGLT2 inhibitors are required to control BMI, as her BMI is around 28.4. So weight reduction is required by diet and exercise, and proper counseling is required for diet and exercise. Then CKD, as patient is having UACR 104, so patient is having microalbuminuria, and looking to that, even his blood pressure is not so high, one has to start AC inhibitor or ARB. Fourth is D is dyslipidemia. Here the triglyceride is 189 and LDL is also 115. So I would like to start with rosuvastatin and fenofibrate put together to control that lipid. And last one is CVD, established CVD. At present, we are not sure about whether patient is having established CVD or not. So we have to do his ECG and echo.
Okay, very rightly said and very nicely put, with ABCDE being the highlight. Moving over to the next question, Mehul sir, in routine OPD, how can one go about with like history, anthropometry, routine workup in such a patient with a busy OPD? So
first of all, very much congratulations to Dhruvi and Vipul bhai. પેલા ડાયાબિટીસના દેવતા કહેવાય આ લોકો. ડાયાબિટીસ થાય તો બહુ ચિંતા ના કરો, બસ ધ્રુવીબેન અને વિપુલભાઈને ફોન કરો તો એમની પૂજા કરો એટલે બધું સારું થઈ જાય. અમને લોકોને આ સીટ ઉપર બેસાડવામાં એમનો પૂરેપૂરો હાથ છે કે કંઈ બી નાનું મોટું જે બી શીખ્યા છે એ લોકોના લીધે શીખ્યા છે, અને એ લોકોના આવા કોન્ફરન્સીસ અને આવા સેમિનાર્સના લીધે અમે શીખ્યા છીએ. પ્રયત્ન કરું છું. શ્રુતિબેનનો બી ખૂબ આભાર કે મેં કીધું કંઈક બોલવા માટે કંઈક સારું બોલવાનું જોઈશે, એટલે પેપર પહેલીથી મેં ફોડી નખાયેલું. મેં ભાઈ મને ટુ બી વેરી ફ્રેન્ક વિથ યુ ઓલ, ક્વેશ્ચન્સ તો એમણે મને આપી દીધેલા અને જવાબો બી મેં શ્રુતિબેન જોડે લખાવી દીધા. મેં શ્રુતિબેન તમે મને જવાબો લખી આપો, મારે બોલવાનું છે. એનું કારણ એકમાત્ર કારણ કે જે મારા ડાયાબિટીસના મેન્ટર છે ધ્રુવીબેન અને વિપુલભાઈ, એમનું ખરાબ ના દેખાય. સો આનો જવાબ હું આપીશ કે ધી સાયન્સ પોઇન્ટ્સ ટુવર્ડ્સ ડાયસ્લેસીમિયા, સો સર્ટેન પોઇન્ટ્સ લાઇક આસ્કિંગ અબાઉટ ફેમિલી હિસ્ટ્રી and taking basic height, weight and waist circumferences, maybe by even a trained receptionist or nursing staff, becomes more important. All of it along with the blood work by checking HbA1c and other basic reports become important for counseling for medication and lifestyle changes. Shruti.
Okay. So routine workup can be done in the clinic, even if as doctors, as clinicians, we may not have the time to do the anthropometry for every patient. We can train our staff at a clinical level. We can train our staff, whether it's a receptionist or a nurse, to do all these basic things. Vikranti.
Can I interrupt?
Yes.
આપણે સોરી, આઈ એમ રિયલી સોરી, આ મેનરની વિરુદ્ધમાં છે, પણ ખરેખર મેનરવાળી વસ્તુ થશે કે આપણે બધા ઊભા થઈને ધ્રુવીના મધરનું સ્વાગત કરીએ. પ્લીઝ 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 બધા ઊભા થઈને બે તાળીઓ પાડીને ધ્રુવીના મધરનું સ્વાગત કરીએ. થેન્ક યુ વેરી મચ. થેન્ક યુ.
That was really sweet, sir. Vikranti, Dr. Vikranti, how often do patients agree for blood work right away? Because we see in our patients, like they are coming to us for vague symptoms and we give them a list of reports to be done. I don't think would agree so easily. So how to go about it, and what routine investigations can be advised, and in case if they say no, then minimally at least what we would recommend to get done at least.
So not all patients who come to the clinic are very health pro and they will not right away agree to the blood workup, but I would like to explain them that the approach to treat the patients with diabetes should not always be glucocentric, and it should be complication prevention as well, since diabetes affect each and every cell of your body and not just the pancreas. I also explain them using the analogy that when you take your car for some repairs into a garage or something, and it is every time you take your vehicle and without even the problems, it goes into maintenance. The entire machine goes into the maintenance, and same way is the human body. So it is the same way that I explain it to my patients. And the routine investigation minimum that I would advise would be HbA1c, FBS and PP2BS if they agree, kidney workup, that is serum create, if they agree to do, and USCR would be more better. Again, the lipid profile, since we are also focusing upon complication prevention. And in the same case that you have mentioned, patient had dysglycemia, USCR was altered. So in such cases, the usual guidelines are retinopathy and kidney screening has to be done annually. But if the reports are abnormal, then it has to be repeated within 3 to 6 months.
Okay, nicely said, thank you. Sanjay sir, how much stress can be given to counseling, diet, exercise and routine monitoring in this patient who is newly diagnosed?
Counseling of diabetes patient is very important. As you all know, diabetes is not a disease of short duration like fever, cold, cough or diarrhea. Diabetes is a lifelong disease. So whenever first time patient is detected for diabetes, patient has to be counseled for at least 10 to 15 minutes. By counseling, that patient will also come in regular follow-up. Patient will also understand about the disease also. So counseling is very important. Counseling not only about treatment, counseling is also required about diet and exercise or lifestyle intervention. In diet, one has to tell that restriction in carbohydrate is required. In this patient, apart from restriction in carbohydrate, if patient wants to reduce his weight, then lipid restriction, fat restriction is also required in his diet. Apart from restriction, in diet, we would understand that he should not do any fast also, because once we start any OHA and if patient is on fast, then his sugar may go down and he may turn into hypoglycemic complication. So in diet, not only restriction of food, but patient has to understand that he has to take at least 3 to 4 times meal. Regarding exercise also, as we all know, 150 minutes in a week or 30 minutes in a day is required for each and every diabetic patient, even a normal patient also. For this patient, if a patient wants to reduce his weight, not only restriction in diet, he has to do some more exercise, because 30 minutes of exercise will give him fitness. But if he want to reduce his weight, then he has to do at least 1 hour of exercise slowly, starting with 10-20 minutes per day, then increase to 30 minutes. Even 1 hour complete should not be done at a stretch, but one can do 30 minutes morning, 30 minutes evening also. Even some variety of other activities like some sports activities or some yoga also patient can do, and by that way he can reduce his he can expand his calories and reduce his weight. And last thing is routine monitoring. Monitoring is very important, particularly diabetes is concerned, because diabetes is a disease in which treatment wholly depends on the sugar level. So each and every patient comes for the first visit, he must understand that this is not a disease that you come today and then you come after 6 months. They have to do regular sugar level and they have to come at regular interval. We have to understand them. These are the normal values of fasting and PPBS. If their values are under good control, patient may not visit to the doctor, but he has to do regular sugar level checkup. He can also do by glucometer, and he can also do in a laboratory whenever some other investigations are also required. So routine monitoring is also required, and whenever patient comes with any abnormal report, we have to change the medicine and we have to do the sugar level again in a shorter interval. That is also what required. So routine monitoring of sugar and other investigations are very important, and this has to be taught to the patient whenever patient comes for the first time.
Very nicely put, sir, because diet, exercise, and monitoring, counseling, all of this, when the person comes to us for the first time with symptoms and then gets diagnosed with certain conditions, especially chronic conditions like diabetes, they are very motivated. So I think that is the correct time we can introduce all of this, and it actually, ghar kari jai, that is the word. It goes in their mind nicely.
They also have to explain about the complications of diabetes.
And prevention of them, yes. Okay. Moving on to our next case. Case number 2. This is Miss B, 27 years old, female. She's an IT professional, a BMI of 30.4. She's married since 1 year and presents with complaints of moderate weight gain, irregular menses, constipation on and off, and this is her basic complaints that she comes with. There are no other significant complaints. Coming to history and examination, no significant past history, not on any routine medications or anything. Mother has a history of dyslipidemia and hypothyroidism. General examination, blood pressure is okay. The systemic examination is okay. RBS has come up as 138. On routine investigations, we can see that she has a low hemoglobin. HbA1c is 6.2. Lipid profile is mildly deranged. Kidney profile, liver profile, kidney profile and liver profile is okay. TSH is raised to 8.2. So coming to our discussion, Mehul sir, looking at the symptoms and basic examination, how should we approach the patient for the management in an OPD setup?
This lady has more or less a sedentary lifestyle with obesity and is recently married and also having family history. Key points from the investigation mainly to be addressed are low HB, pre-diabetes, dyslipidemia, and borderline thyroid. It would be important to explain to her about weight loss specifically by lifestyle management, diet and exercise. For diet, maybe a dietitian consultant or if not available, we can have some basic diet plan ready based on calories and can be given to the patient, and same goes with exercise schedules. Shruti.
Okay. So, next question, Dr. Vikranti, any thoughts on thyroxine treatment, whether to give or not to give, because her TSH is a little raised?
So her TSH is around 8.2. With her having symptoms of irregular menses and weight gain, her BMI is again high. So we would have to look for the symptoms of hypothyroidism. If they are present, then we can classify her into subclinical hypothyroidism. Again, we would like to test for anti-TPO. Okay. If the antibodies are positive, then definitely she should receive anti-thyroid medications. Other thing, she is in the reproductive age group, she is married, and if she is planning to plan a pregnancy, again the TSH values 8.2 is not acceptable. It should be around 2. Other thing that even in obesity, because of leptin, the higher stimulation to TRH cause increase in TSH. The peripheral conversion of T3 is high, and again TSH is not suppressed. So obesity is one of the reason for her having high TSH levels. But yeah, we can start with low dose thyroxine treatment for the lady since she is in the reproductive age group, and we will recheck TSH level with lifestyle modifications after 6 weeks.
Great, very nicely said, especially the antibody part. Yes, we need to check the antibodies. Even she has a family history, so yes, we need to check those parameters, and it's better to start her on thyroxine treatment. Sanjay sir, at what point would this patient require a referral to a specialist?
Most of the obese patients think that their weight is because of thyroid. And in this lady also, TSH is little high. So this lady will also insist that because of thyroid, she is having very high weight. But thyroid could not cause that this much of BMI of 30. So we have to understand that lady that your weight is not because of thyroid. Even we will give treatment for hypothyroid, then also your weight is not going to reduce. And if at our family physician level, we take 20 minutes or 30 minutes of time of that patient and we insist that we should start treatment for obesity, but then and then also patient will not be ready to take obesity treatment. So here the reference is required particularly to reduce the weight, because as we all know, obese people tries a lot doing diet control and exercise, and then also weight is not controlled. And we all know that the reason is leptin behind her obesity. So we have to send this patient to endocrinologist first. And if that lady has been married for 1 year and plan to do plan for pregnancy, then gynecologist reference is also required. But at family physician level also, after doing anti-TPO, we can start thyroid treatment also.
Yes. Nicely said. I mean, thyroid treatment we can start. We can start the basic weight management also. There may be an improvement because she'll be starting for the first time, and then if required, we can even take it ahead with the specialist. Okay, Mehul sir, how can we convince this patient regarding importance of controlling BMI and HbA1c?
Shruti, in our routine OPD, it is very often difficult to actually sit and counsel the patient periodically. Basically, हमारा family physician में तो संजय भी જેવી લાઈનો તો ના લાગે, પણ નાની મોટી સંજય ભાઈ 100 જોતા હોય તો અમે 10 જોઈએ, પણ 10માં બી એમ થાય કે ના સાહેબ હવે ડાયાબિટીસ આવ્યો છે, ચલો ફટાફટ દવા લખી દે. સિસ્ટમેટિકલી નથી જતા 100%, અને એવું શાંતિથી કદાચ વાત બી નથી કરતા. સંજયભાઈ જોડે અમે બહુ બધા શીખીએ છીએ. બહુ દિલથી કહું છું અને બહુ સાચી વાત કહું છું કે સંજયભાઈ સરસ રીતના ડાયાબિટીસ ક્લિનિક ચલાવે છે, અને અમે લોકો ઘણી બધી વાર એમની સલાહ લઈએ છીએ કે ભાઈ તમે આ પેશન્ટને મારે શું કરવું શું નહીં. એટલે આનો રસ્તો અમે લોકો એ કાઢીએ છીએ કે ભાઈ શાંતિથી પેશન્ટને બીજા દિવસે એવા ટાઈમે બોલાવીએ અને બેસાડીએ કે ભાઈ આપણે આ કરવાનું છે. એવા ઘણા પેશન્ટ હોય કે જે શાંતિથી વાતચીત કરી શકતા હોય. તો બેઝિકલી ફોર ધીસ પેશન્ટ this is the kind of patient who we manage well can even prevent diabetes in future generation and family too. So it is imperative to talk her about for this patient for weight management and glucose control. Also need to discuss while prescribing about whether they are planning to conceive or not, and need to explain the importance of strict glucose control in pregnancy. That's why. But I request Dhruvi and Vipul bhai કે એટલીસ્ટ અમારા ફેમિલી ફિઝિશિયનમાં અમે બધા ઘણા બધા માનીએ. સંજયભાઈ તો એમાં બહુ માહિર છે, પણ અમે બધા ઘણા બધા માનીએ કે ભાઈ ડાયાબિટીસ આવે એટલે અમે 2-4 ગોળી લખી દેતા હોઈએ છીએ, મારા જેવો ડફોર ડૉક્ટર. પણ બહુ સાચી વાત કહું તો એક ફેમિલી પ્રેક્ટિસ, સોરી હું સબ્જેક્ટની વિરુદ્ધમાં જઉં છું, પણ ઇટ ઇઝ અ ટાઈમ કે અમારી ફેમિલી પ્રેક્ટિસ ધીરે ધીરે ઘટતી જાય છે. બધાની ફેમિલી પ્રેક્ટિસ ધીરે ધીરે ઘટતી જાય છે, અને અમે લોકો એસોસિએશન લેવલે નાના મોટા ડાયાબિટીસ ક્લિનિક અને હાઇપરટેન્સિવ ક્લિનિક કરવાનું બધા વિચારી રહ્યા છે, અને એમાં આપ લોકોની બહુ મદદ જોઈશે. શ્રુતિની મદદ જોઈશે, તમારી મદદ જોઈશે, ધ્રુવી, વિપુલભાઈ, તમારા બધાની મદદ જોઈશે, જેથી કરીને અમે લોકો અમારા પેશન્ટને સારું પીરસી શકીએ અને સારું થઈ શકે. યસ ધ્રુવી?
Yes, yes.
Primary care physicians are the most important part of the ecosystem for any
Everything.
non-communicable disorder. And I don't think કે અમારે તમને ભણાવવાનું. I think you are
તમારી પાસે એટલો એક્સપિરિયન્સ છે that we learn from you.
ના એ વસ્તુ અલગ છે, પણ બહુ ટુ બી વેરી ફ્રેન્ક વિથ યુ, આપણે કોઈ પણ પેશન્ટ હોય, પેશન્ટને આપણે સારી મેડિસિન આપી છે અને સારી એડવાઇસ આપી છે, અને એ અમારા ફેમિલી ફિઝિશિયનના એટલે બહુ ઓછા છે. એટલે મારા જેવાના તો બહુ લિમિટેશન જ છે કે હું સારું લખી શકું, ડાયાબિટીસની ટ્રીટમેન્ટ આપી શકું. પણ તમે જો આવશો તો સંજયભાઈ જેવા બી કદાચ વધારે સારી રીતના કંઈક પીરસી શકશે, એ વાત નક્કી છે. તો વી કેન પ્લાન ટુગેધર કે એવા ડાયાબિટીસ ક્લિનિક પર્ટિક્યુલરલી અવર કે ભાઈ મારું 10થી એક ક્લિનિક ચાલતું હોય તો 1થી 1.5માં અમે ડાયાબિટીસ ક્લિનિક કરીશું, કે એમાં 3 કે 4 પેશન્ટો જોવાના હોય. So we have a audio consultation or video consultation with you people.
Sure.
And we'll take your advice.
Absolutely, sir.
And
The
in
care
future,
and every one of us.
diabetes clinic will be also separated by obesity clinic.
Correct.
Oh, yes,
correct.
very
Obesity clinic will be there in future.
થેન્ક યુ સોરી સુધીઓ
Thank you.
Here
No,
the
no, sir.
patients HbA1c.
Actually, I was just going to come to that. Like, even though we see patients, we have seen that the first point of contact any individual has, okay, be it even a person from a doctor's family, as simple as that, even from a doctor's family, first point of contact is a family physician. In fact, mara nani ji sir ne batave chhe. So it is the first point of contact that any person has, because they are very open about their life with their family physician, which they may not be with any specialist doctor, કારણ કે આપણે એના માટે નવા હશું. But with a family physician, they are so open, they can discuss everything. It's not just medicine they talk, they get even relieved of their basic stress when they come and meet you.
સો ટકા સાચી વાત છે. આમાં કે આ લેડીમાં કંઈક માથાકૂટ હોય કે એના હસબન્ડ જોડે માથાકૂટ થયું તો 100% અમને મળવા આવે કે સાહેબ કંઈક કરો. 100%ની વાત છે. યસ.
Yes. So, okay. So, Dr. Vikranti, do you think this patient should be given statin therapy or not?